Okay, very good morning, guys. So, welcome to surgery session. So, previously we stopped at DCIS grading and in DCIS classification. So, according to the pathology, we will classify DCIS into nuclear grade and necrosis orientation, right? So, according to the pathological features, it is classified into nuclear grade and necrosis. Now, in regarding the nuclear grade, it is classified into low grade DCIS and high grade DCIS, right? Now, coming to the difference between low grade and high grade DCIS, this is low grade and this is high grade, right? So, what are the differences between this low grade and high grade ductal carcinoma in situ, right? DCIS. Now, coming to the low grade, it's actually cribriform, papillary and micropapillary. Remember, it's cribriform, papillary, and you have one more, that is micropapillary, right? Now, coming to the high grade DCIS, we just make it as solid carcinoma, and another one is comedocarcinoma. So, in low grade we have papillary, micropapillary, cribriform, and high grade we have solid carcinoma and comedocarcinoma. Now, coming to the investigations, regarding the investigations part, generally in case of DCIS there is microcalcification. As you all know, there is microcalcification, but for the detection of microcalcification you go for mammography. But if you really want to go further, so you can take it like the best investigation of choice for the so-called soft tissue, for detecting the soft tissue abnormality is obviously MRI. But remember, MRI can't detect the microcalcification. So if you ask me the best investigation for determining the microcalcifications, then it obviously mammography. But if you ask me the best investigation technique for detecting the soft tissue abnormality is always MRI. Okay, I think you got my point, right? So the best investigation for detecting the soft tissue abnormality, that is MRI, but for the best investigation for detecting the microcalcification, it is mammography, right? Now, what will you see in mammography? Obviously in mammography you will see microcalcifications. Microcalcification is obviously seen in the mammography, and mammography is the best investigation method for detecting microcalcifications. Now, how much diameter they can be? Most probably they have a diameter of 0.5 mm. So 0.5 mm diameter microcalcified deposits can be observed. Now, we're coming to the treatment of DCIS. What is the treatment of ductal carcinoma in situ? For example, if it's a non-palpable DCIS, then we can go for excision with needle localization. And you can also send this specimen for specimen mammography. Remember this. Now, if it is in case of a low grade DCIS, you will simply do with lumpectomy. For example, if it's a DCIS with limited disease, or it is a high grade DCIS. If it is a high grade DCIS, simply you do lumpectomy plus radiotherapy. So lumpectomy plus radiotherapy. Why you should do radiotherapy? Because to avoid recurrence. Okay. So if it's high grade, you do lumpectomy plus radiography. Okay. Understand? Now we'll go on with the next type of carcinoma, that is lobular carcinoma in situ, LCIS, right? Lobular carcinoma in situ. It arises from the terminal duct lobular units. Always remember, the origin of LCIS is it arises from the terminal duct lobular units. And lobules, and as previously we already discussed, lobules are seen only in females. So obviously lobular type of carcinoma is seen only in females, right? Whereas in males you have ducts only, whereas in females you have both ducts and lobules. Remember, now these conditions are multicentric and they are generally bilateral, so there is an increased chance for bilateral breast cancer. Why we should discuss bilateral? Because there is a chance that if the procedure needs to be done, you should go for both the sections. To work bilaterally, you should go for the resection. So this condition is bilateral. So this, remember that. Now coming to the pathology. The LCIS, in case of LCIS, there is a presence of a cytoplasmic mucoid globules, cytoplasmic leukoid globules. Wait, some of the doctors are asking me, sir, please write neatly. Okay, I will write here. So coming to the pathology, use here pathological feature of mucoid globules. Mucoid globules, these are actually cytoplasmic mucoid globules are observed in the pathological features. And what is the histological hallmark of LCIS? The histological hallmark is the tumor cells are arranged in a linear pattern. The tumor cells are arranged in a linear pattern. Now that is why it is also known as, I will write with red ink, it is also known as Indian file pattern. Indian file pattern, which is considered to be the histological hallmark of LCIS. Okay. Now what are the findings in mammography? What are the findings in mammography? Obviously, no calcifications can be found in the tumor itself, but the calcification can be found in the neighborhood. Remember, the calcifications can be seen in the neighborhood tissues. Remember, is always. Now in case of LCIS, obviously neighborhood calcification is seen. Remember, in case of LCIS, neighborhood calcification is seen. So in the tumor itself you don't observe any calcification, but in the neighborhood regions you see the calcification, right? Now what is the histological hallmark of LCIS? That is Indian file pattern, because the tumor cells are arranged in a linear fashion, right? Now what is the treatment? The treatment is very simple. If it comes to drug treatment, it is tamoxifen and raloxifene citrate. Now we can also go for prophylactic, something like prophylactic bilateral mastectomy. If you really want to go for it, you can go for it, no problem. Or else in the preliminary stages you can just go on and wait for if there is any arise of any consequences, you just observe the condition, or you can also go for chemo prevention. But if it's drugs, tamoxifen and raloxifene, or if you want to go for procedure, you can go for prophylactic bilateral mastectomy, right? Now we will just look into breast cancer in detail, right? What is the most common histological type? The most common histological type is adenocarcinoma. Always remember, the most common histological type of breast cancer is adenocarcinoma, as we already discussed. Now what is the most common subtype? If you ask me the most common subtype, it is invasive ductal carcinoma. If you ask me the least common subtype is papillary. Previously we already discussed. Now if you ask me the most malignant type of breast cancer having worst prognosis, that is IBC, inflammatory breast cancer. Worst prognosis and most malignant. Now least malignant with best prognosis, we already discussed, that is tubular carcinoma. Okay. Now there is a norm, like normally breast cancers are always or most commonly on the left side. Breast cancers are most commonly on the left side. And do you know the fact that the two breasts in a woman, they are not alike. Actually slightly one of the breast is larger than the other breast. Then mostly it is left side. Left breast is larger than the right breast. Okay. So coming to one of the this is a functional aspect of breast. If we check that this is if we check that this is a breast, if we just divide it into quadrants, now this is the lateral side, this is the medial side, this is upper medial quadrant, upper lateral quadrant, lower medial quadrant, lower lateral quadrant. Now here I will just scrap it off, and here you will have something called the like this. Yes, like this. Now this is called the axillary tail of Spence. Axillary tail of Spence. It is present on the upper lateral. Now this upper lateral quadrant is the most common site for breast cancers. That is upper lateral quadrant. How much? There is a percentage, that is nearly 60% of the cancers arise from the upper lateral quadrant. And you go for upper medial, that is 12%. You go for lower medial, that is how much? 6%. You go for lower lateral, that is 10%. So the maximum maximum breast cancers, they arise from which quadrant? That is upper lateral quadrant. And there is an extension called axillary tail of Spence, which is extending towards the axilla. This is the basic that you should all remember, guys. Don't forget this. Now in the above figure, in the above thing, you just see here is the axilla. You just remember this is a hallmark. The upper lateral quadrant is the most common quadrant, that is nearly 60% of the breast cancers are in this, right? So axillary tail of Spence, I think you can remember. Now some of the doctors may get a question like, why axillary tail of Spence is the most common area for the breast cancers? Because it has the maximum amount of tissue. It has the maximum amount of breast tissue. It has the maximum amount of breast tissue. That's why it stands as the most common site for breast cancer. So most common site is upper outer or upper lateral, you can call it, and least common site is lower inner, or you can call lower medial. This is the least common, this is the most common, this is the most common site. Okay, now in adenocarcinomas, always remember one thing: the most common route of spread is, in adenocarcinomas, the most common route of spread is lymphatics. Remember this, lymphatics is the most common route of spread in adenocarcinomas. Now if you ask me, in carcinomas, what is the most common route of spread, then it is obviously hematogenous, that is through blood. Hematogenous, that is through blood. Okay, now just remember one thing: adenocarcinoma means carcinoma arising from glands. What is a breast? Breast is actually modified sebaceous gland. Now can we say like cancer arising from the breast is also a type of adenocarcinoma? Yes, obviously, because breast is a gland. Breast is a modified sebaceous gland, right? Now if obviously if some sort of malignancy arises from the breast, so obviously you can call the breast cancer as a adenocarcinoma. So breast cancer is also can be called as a adenocarcinoma. So if breast is an adenocarcinoma type of cancer, so the most common route of spread is lymphatics. So the breast cancer's most common route of spread is lymphatics. Now what is the most common site of metastasis? Most common site of mets towards the bone. Which bone? Vertebra. Which vertebra? Lumbar vertebra. Which vertebra? Lumbar vertebra. Now if you ask me what is the how the bones are involved, actually how the bones are involved in case of a breast cancer metastasis, bones are actually involved through hematogenous spread. Just remember this statement, don't forget this. Bones are the secondaries, the primaries are breast. The primary is breast. From breast it goes towards bone with the help of hematogenous spread. Now if you ask me the order of metastasis, regarding the spread, then it's obviously most common bone site to undergo secondary mets, that is lumbar vertebrae, more than femur, more than thoracic vertebrae. Okay, so you can just drop it down with the mnemonic like LFT. Lumbar vertebrae more common than femur, more common than thoracic vertebrae. Okay, now what is, if you ask me, sir, what is the most common primary for both osteolytic and osteoblastic conditions? That is obviously carcinoma breast. So carcinoma breast is the primary carcinomatous condition whose mets will cause the most common osteolytic or osteoblastic secondaries. Now if in the both of the condition, what is most common, whether it is osteolytic type of secondary or osteoblastic type of secondary? It is osteolytic type of secondary, the most common in carcinoma breast or the breast cancer metastasis. Osteolytic type of secondaries occur. Now if the patient has a bony metastasis, can the nerve compression may occur? Obviously, so nerve compression also may take place. So that is the reason why the bone secondaries, the carcinoma breast metastasis to the bone, obviously the patient one comes with a complaint of backache. So backache with weight loss and some abnormal pathological investigations in a female more than 45 years, always check for carcinoma breast, examine the breast. Okay. Now, if you ask me, the bony metastasis in a breast cancer patient, will it cause death? No, the bony metastasis will not cause death. Remember. Then what is the most common cause of death in a breast cancer patient? What is the most common cause of death in a breast cancer patient? Can anyone tell? Breast cancer patient, what is the most common cause of death? Anyone? It is nothing but malignant pleural effusion. This is the most common cause of death in a breast cancer patient. It is malignant pleural effusion. Right or wrong? Now, what is the pathway of spread? What is the pathway of spread in a breast cancer? What is the pathway of spread in a breast cancer? Obviously, the breast cancer cells, first they will invade the posterior intercostal plexus or posterior intercostal vein. Then from there they will invade the vertebral venous plexus. So the posterior intercostal vein is the first vein to receive the invasion from the breast cancer. Now the vertebral venous plexus, they are also called as, with which name they are called? They are also called Batson's plexus. Remember. Now through the Batson's plexus, the malignant cells reach the lumbar vertebra. Through the Batson's plexus, the malignant cells reach the lumbar vertebra. And also, to which sinus they go? To dural venous sinus. They also go to dural venous sinus. Right. Now, you may ask me a question, sir, how this Batson's plexus or the vertebral venous plexus, how they can easily allow the invasion or transfer of these malignant cells to lumbar vertebra and dural venous sinuses? Because these Batson's plexus are valveless. They don't have any valves. These are valveless. So the breast cancer cells, I'll write here the breast cancer cells to posterior intercostal vein, from posterior intercostal vein to vertebral venous plexus, or also called Batson's plexus, from Batson's plexus to lumbar vertebra and dural venous sinuses. Right? Everyone clear? Right. Now, after reaching the dural venous sinuses, there are chances like they may affect the leptomeninges also. These malignant cells, they may also affect the leptomeninges. Right. So from leptomeninges, it may also take the invasion towards the brain. So it may also invade these malignant cells. They may also invade the brain. Metastasis may take place towards the brain also. And if you ask me, with this statement, if you ask me what is the most common primary metastasis for leptomeningeal condition, for leptomeningeal metastasis, what is the most common primary for leptomeningeal metastasis? That is breast cancer. Now if you ask me what is the most common primary for brain metastasis, obviously it is carcinoma lung greater than carcinoma breast. For brain, the primary metastasis will be from carcinoma lung followed by carcinoma brain. If carcinoma lung is not in the option, then it will be carcinoma breast. But for leptomeninges, the most common primary metastasis will be from breast carcinoma only. Okay. What someone is asking, what is meant by primary? See, primary is nothing but, primary is something from where it starts. That is called a primary. And secondary means to the point where it spreads, to the point from where, see, I will explain with an example. For example, a woman got breast cancer. So obviously in the cancer means the tissue will have some malignant cells, right? So she got the breast cancer itself. So directly she got a cancer to a particular tissue. Now her breast cancer tissue will be having some malignant cells. Now this one will become primary. This one will become primary. Now from here the malignant cells will be spreading towards the which point? For example, take it like lumbar vertebra. Through hematogenous spread, that is through blood, through hematogenous pathway, these malignant cells, I will write here, these malignant cells will flow through blood and they will invade the lumbar vertebra, and here also they will cause the carcinomatous lesions, or this lumbar vertebra may also be affected due to the carcinomatous condition. Now this one will become the secondary. This one will become the secondary. That is what mean by primaries and secondaries. Okay. See, there is no need to feel shy just explaining all these ETPT things. Right. This might look like a simple things, but still some people will get confused. What becomes primary for what becomes secondary for what. So in the previous scenario, lumbar vertebra will become secondary for the breast cancer and breast cancer will become primary for the lumbar vertebra. If someone wants to explain this whole concept in a single statement, breast cancer or the breast, or you can simply call it like the primary for the lumbar vertebra malignancies is the breast cancer. The primaries, right? Secondaries will obviously be lumbar vertebra. Okay. Now coming to the clinical features of breast cancer, we will just look into some clinical features. We'll just look into some clinical features. Now what is the most common presentation in case of a breast cancer? Obviously it will be some sort of a lump. So sometimes the lump can be deep, or sometimes you can see like the lump can be felt on the skin. So the lump, sometimes it can be felt, sometimes it can be deep. So obviously how you can just notify this, how you can just understand the situation. Now what is the most common presentation in case of this type of breast cancer patients? Obviously it will be lump. So how you can recognize this lump? See, most of the women who cross something like 25 years or 30 years at least, they will be asked to do a self-examination of the breast by themselves in their home itself, right? You can just simply divide the breast into 4 parts and you can just simply palpate in each of the quadrant by in a particular special way. So so easily she can just palpate herself and she can recognize if there are any sort of lumps in the breast or not, right? So the most common presentation will be lump. Now what happens is, in most of the cases, an educated female, right, for example if she is illiterate, she can identify a lump. She can simply identify a lump which is formed, and what she does is she immediately goes to a doctor. Doctor, in my breast, in my right side of the breast towards the lateral side, I feel some sort of a lump when I am wearing bra or when I am wearing a petticoat or something. She just says like that, when I am wearing my bra, I just got to observe that there is a hard structure I can palpate under the skin. I don't know what it is. So if she comes to you, or even though the female is not educated enough, if she is not educated enough to identify breast lump, but still she will come. But most of the times educated people means surely they will come to the doctor. But if she is an uneducated, obviously she will miss it, she will just ignore it, she will think like it has occurred due to some heat or due to less intake of water. She thinks like that. Most of the uneducated people, I am not degrading anyone, please don't think like that. I am not degrading anyone. Some of the uneducated people, what they think means, if they feel any sort of hard structure in their breast, they think like, okay, it might be due to heat, it might be due to low intake of water, it may be due to some spirit or some godly thing like this. So something has happened to my breast, so they don't come to doctor itself, they feel some shy, right? So it's not a wrong thing, right? But what we have to do is we have to bring the social awareness, right? So what happens is, due to that lump, see, lump is it's a different anatomical as well as morphological structure. So slowly the lump grows, and what it does is it makes the breast asymmetrical. At one point of time it makes the breast asymmetrical, and the coordination goes off. The architecture will also get disturbed. The architecture of the breast becomes distorted, right? Slowly the breast size increases. Now simply we can say, like, even sometimes this lump you see here, sometimes it can even affect the skin also. It can even affect the skin, sometimes the chest wall. It might even spread to the pectoralis major as well as the pectoralis minor muscle also. Muscle can also be involved in rare conditions, right? Now skin involvement, sometimes it can cause the skin fixity. It just makes the skin like a fixed skin, it's just fixed, it's not moving freely on the breast, it's just fixed. Now if there is a nipple involvement, if there is an involvement of nipple, it may leads to nipple retraction or nipple deviation, or sometimes you can also see some sort of ulcers on the nipple, that is ulceration also. Now if there is any chest wall involvement, so obviously she will observe that there is a fixity of the chest wall, right? Now let's discuss each of the signs of breast cancer, just simple in a normal manner, right? Now for example, what is meant by a retracting? See, I don't have pictures, but I will try to show it as simple as it can. Okay, I will try to show it as simple as it can. See, this is a normal breast, but if you ask me, see here the nipple is normal, but here you see there is a small retraction to the inside. There is a small retraction. You see this? See, if you see the image, you can understand it clearly. You just go and Google it in the retracted nipple, right? So there will be a small retraction towards the inside of the breast. So that is called a retracted nipple. This condition is called a retracted nipple. And sometimes you can also see edema. Sometimes you can also see a cutaneous edema on the breast. Sometimes the breast also have some sort of a orange peel like appearance. You have seen the orange, na? If you ever seen the orange peel, how it looks, it has some different structure, some dotted structure. So that is an orange peel like appearance. The breast skin also will become like that. The nipple simply gets retracted. Now that condition is called the orange peel like appearance of the breast is called as PUD orange. Now this PUD orange, always remember, it is the most conspicuous sign. It's the most conspicuous sign of a breast carcinoma. This PUD orange is the most conspicuous sign of a breast carcinoma. Always remember. So what are some of the causes of PUD orange? But why actually the PUD orange occur? Why actually the PUD orange occur? PUD orange occur because what happens is the tumor cells simply enters the lymphatics. Remember this concept, very important. It enters the lymphatics of the skin, and simply these tumor cells cause to lymphatic obstruction. Now what lymphatic obstruction does is, in result, it causes cutaneous edema. Now as a result of this cutaneous edema, that breast skin appears like a orange peel, or otherwise called as PUD orange. Right? You understand? Now that is the reason behind the purely orange skin. Now we have got to know the reason behind the skin dimpling. I mean skin orange peel-like appearance. We got the reason. Now we will discuss one more thing. If there is a skin dimpling like a dimple, dimple pimple, like a dimple, then obviously there is an involvement of ligaments of Cooper. There is a chance of involvement of ligaments of Cooper. What are these ligaments of Cooper? They are actually the supportive ligaments of the breast. They are the supportive ligaments for the breast framework. Now this sign of skin dimple due to invasion or due to spread of malignant condition towards the ligaments of Cooper, this skin dimple is called as dimpling. Okay, that sign is called as dimpling sign. Now sometimes the skin may get wrinkled, sometimes the skin may get folds, right? Now that type of, if the skin gets wrinkles and folded like conditions, then that is called as puckering. Right? So you will get some images. See, in the image mala we will discuss all the images. The IPL also signifies images Premier League. In that we will discuss nearly 1260 images from all the subjects. We will discuss 100 images per day. In 12 days we will finish all the images. So we have image mela also, that is IPL, images Premier League also. So don't worry about it. Okay, so that the skin of the breast appearing in a wrinkles, or it has shown the folds, it has been undertaken a form of folds, then that is called as puckering. Okay, right. Now if there is a sign of puckering, then obviously you can just guess, like there is an infiltration of, there might be a chance of infiltration of ligaments of Cooper. Okay, now up to that it's okay. Now sometimes you also see multiple nodules, ulcerations also can be seen. So mostly this can be due to involvement of breast skin and the chest wall. Now that condition where we see multiple nodules and ulceration due to involvement of breast skin and chest wall is called as cancer and cuirass. There is formation of nodules and ulceration due to involvement of breast skin and chest wall. Okay, now we will just discuss some of the signs and symptoms of metastasis. For example, if you see the bony metastasis, it causes backache. For example, if there is a brain metastasis, obviously the patient complains of headache. For example, if the metastasis occurred to the liver, the patient complains, or you can see the sign of jaundice in the patient. For example, if the metastasis has occurred to the lung or pleura, then the patient comes with a complaint of dyspnea. Or sometimes the patient also suffers from anorexia and severe weight loss. So these are all some of the signs and symptoms that the patients with breast cancer secondaries or the breast cancer metastasis comes to you with. Okay, now we will discuss something called triple assessments. Most of the times you hear in your final year in the surgery there's something called as triple assessment. Even in the gynecology also you observe this triple assessment. What is this triple assessment? In this triple assessment, the clinical signs and symptoms are assessed. Clinical signs and symptoms are assessed. Now we'll do a imaging, right? We'll do a imaging. What imaging we will do? We will do either mammography or ultrasound imaging is done, and also we will also do something called tissue sampling. What is the tissue sampling? If it can be FNS, fine needle aspiration cytology, or you will do biopsy, BX means, see, I will tell this also. SX means surgery, BX means biopsy, MX means management, RX means not RX 100, RX means treatment. Okay, these are all the Latin jigs. Okay, so here BX means biopsy. Okay, BX means you will do FNAC or biopsy is performed. Now regarding biopsy, there are different names that you can indicate on it. There is something called true cut biopsy, there is something called core cut biopsy, there is something called needle cut biopsy. So you can do any of these types of procedures, any of this type of biopsy can be done. Now the main important MCQ for NEET PG, I am telling, for NEET PG, the positive predictive value of triple assessment is 99.9%. And now these three conditions should be read very perfectly. It should be known. What is the triple assessment? Clinical signs and symptoms of the condition can be assessed. Mammography or ultrasonography should be done, as well as the tissue sampling with the help of fine needle aspiration cytology or biopsy should be performed. Biopsy, you have different types, that is true cut, core cut and needle cut. Possibility value is 99%. Now, the first investigation done in a case of a suspected case of breast malignancy is mammography. Breast cancer is mammography. Now the investigation of choice, this is the first investigation. Now if you ask me the investigation of choice for the diagnosis of breast cancer, then it's obviously biopsy. It's obviously biopsy. The investigation of choice for diagnosis of breast cancer is biopsy. Now we discussed about FNAC and biopsy, but what are actually the differences between FNAC and biopsy? We'll discuss. Here the side view of the needle in FNAC is 20 to 26 gauge, and here it is 14 to 16 gauge. And here actually a cytopathologist is required. Remember, a cytopathologist is required. But in case of biopsy, a general pathologist or a person who is expert in the biopsy collection, he can do it. And one more important thing is biopsy. With the help of biopsy, it is easy to differentiate between DCIS and invasive ductal carcinoma. Invasive ductal carcinoma, you can differentiate it with the help of biopsy. Now there is one more thing that you should check about FNAC, that is, it is very hard to distinguish between carcinoma in situ from invasive ductal carcinoma, but with the help of biopsy we can easily differentiate. Now in case of FNAC, there are high chances for false positive or false negative also, right? Now one more thing about FNAC is it is very difficult to assess the hormonal receptor status. It is very difficult to assess the hormonal receptor status, whereas here hormone receptor status can be very easy to access, easy to assess the hormone receptor status, as well as the biopsy is more painful. Trust me, biopsy is very painful. Whatever biopsy it can be, it is painful. Now just coming to the next one, that is mammography. We'll discuss something about mammography. Now what is the main use of mammography? It is the investigation of choice for screening of breast cancer. Remember, now it is recommended to all the females, irrespective of condition, irrespective of the scenario, it is recommended to each and every female. Now according to the current recommendations, I will tell you one thing: mammography should be started in all individuals at the beginning of 45 years annually. 45 years annually. So, but in the gynec and obs we will discuss it even more better. But right now we will just discuss only up to this. Now just remember the name of the X-rays that is used, that is Bremsstrahlung X-rays. It is Bremsstrahlung X-rays. Now what is the percentage of, what is the amount of radiation that is being exposed? That is 0.1 centigrade per study. That is 0.1 centigrade per study. Now generally mammography does not increase the risk of breast cancer, like most of the people think. But why it doesn't increase the risk of breast cancer? Because the radiation of exposure is only 0.1 centigrade per study. It is very much less radiation. It is very less radiation. You don't even think like that, right? Now one mammography is equal to, remember, 4 chest X-rays. One mammography is equal to 4 chest X-rays. Okay, finished. Now some of the students may get a doubt like, sir, how mammography is done, how actually it is done. If you can just give us with the help of some image or some. See, I will just simply tell you with the help of a drawing, right? So this is a stand. You will have 2 clips. Right. So the patient's breast will be kept, or it is well settled or well placed inside this clip like this, right? Now this is the chest of the patient. Here the patient will present here. Right. So the patient will keep her breast here, right? And she will stand like this. Sorry, my drawing is like she is like a conjuring villain, but don't think like that, okay? I just gave you one representation, that's it, okay? Don't think like that. Just because she is evil, she got breast cancer, okay? Let us think like that, okay? So she will place her breast like this. So this is the breast, right? This is the breast. She placed her breast inside these plates, right? So here there will be a screen, okay? So she will place, and the rays, see here there will be a chamber like this. So there will be a focuser. This focus will project some X-rays on them. What are the X-rays that are used in mammography? That are known as Bremsstrahlung X-rays, okay? Now what are the components? Some of the components of the breast imaging, that is mammography. We'll just get to know the names, right? Just names are enough. Don't go into the detail, please. You won't be asked in INACT, right? So you'll have something called rotating anode. You'll have something called rotating anode. Next you have something called compression paddle. Compression paddle. Did you check what is that compression paddle? See, you have this thing now. And the breast will be kept like this. This is called as compression paddle, okay? And you have one more thing, that is film. So where will be the film? Obviously the film will be here. Why the film is placed here? See, why the film is placed here? Because the rays are coming like this, and the rays will be projected on the breast, and it will be projecting onto the film. So that is the film. So breast is rested on the film. The compression paddle, what it does is, see, this is the compression paddle. This is the compression paddle. It will compress the breast like this towards downwards, right? So there are actually 2 views in mammography. First one is craniocaudal view, and second one is mediolateral oblique. Craniocaudal view and mediolateral oblique. In case of cranial or craniocaudal view, you can observe the medial aspect and breast compression is assessed. Medial aspect of the breast and breast compression is assessed. But when you come to the mediolateral oblique view, it helps in giving information about the maximum breast tissue. Maximum breast tissue information can be extracted from the mediolateral oblique view, right? So the ML oblique view is the important view where you can extract maximum amount of information regarding the breast tissue. And one more thing is, in MLO you can also assess the information about the axillary tail of Spence. That is the advantage of medial lateral oblique view. So that is the differences between craniocaudal and MLO. Craniocaudal view is medial aspect is assessed and breast compression is assessed. MLO view is, that is medial lateral oblique view, is maximum amount of breast tissue can be assessed, as well as axillary tail of Spence also can be assessed in MLO view. Okay. Now what are some of the advantages of mammography? I will just tell it orally, you just listen. It can detect non-palpable breast cancer first and foremost. And one more thing is, carcinoma of breast in its early stages only you can easily detect with mammography, so that you can treat with initially you can start the treatment early, right? So hence you can say one thing, that good prognosis is one of the advantage of mammography. So right here, good prognosis is one of the advantage of mammography. Remember, good prognosis. And also, if you diagnose the stage initially only, you can obviously decrease the mortality. That is also advantage. And also it will improve the survival more than 33%. And always remember the findings to be focused in the mammography. So what are the findings that you should focus in a mammography? Now this is important. What are the findings that should be focused in a mammography? If there is nipple retraction, whether there is nipple retraction or not, you should see. If there is skin thickening, you should observe. If there is any micro calcifications, that one you should observe. And if there is any obliteration of retromammary space, this is very important guys in Inicet aspect. Obliteration of retromammary space. Now what is this space? What is this retromammary space? It is the space between the pectoralis major muscle and breast. It is the space between the pectoralis major muscle and breast. Now you should also look for any opacity, if the opacity is irregular or not. If there is any irregular opacity, you just check for these things. Now we discussed all the things, we discussed each and every point. Now let's check what are some of the differences which make benign different from a malignant condition, which make benign disorder different from a malignant condition. Guys, I think I'm not writing because I don't want to waste much of the time, because I know you have studied at least for once. So I think of that no need to write all the things, right? Okay, so that is why I'm asking, please listen to each and every word pinpointedly. Don't lose any useful information. I am begging you, literally. Each and every statement is important in Inicet. For example, MLO view is helpful in assessing the axillary tail of Spence. This can be a most probable MCQ. It can be a potential MCQ, obviously. For example, all of the things are true about MLO except, for example, in that the third option, the examiner may give like MLO cannot assess the axillary tail of Spence. It is false. MLO can assess the axillary tail of Spence. That is one of the most biggest advantage of MLO. And one more advantage of MLO is maximum breast tissues information can be extracted with the help of MLO view. MLO means mediolateral oblique view. Okay, so that is why I am asking, please don't miss any statement. Every statement I have written here is a potential MCQ. I will extracted the major cream of the surgery, which is very useful for the Inicet. Okay, now coming to the differences between benign and malignant region. Now Coming to the opacity, benign have a regular opacity, whereas malignant have irregular margin. It has irregular margin. Now it has a smooth margin in case of benign. Now benign disorder is homogeneous because it is smooth, it is equalized, whereas malignant is heterogeneous. Benign is low density, malignant is high density. Benign has thin halos, whereas malignant has wide halo. Halo means empty appearance. Malignant has wide halo, it has a wide empty appearance. Benign shows macro calcifications. Benign shows macro calcifications, that is measuring more than 0.5 mm, whereas malignant shows micro calcifications measuring less than 0.5 mm. Now benign, it is associated changes in breast are absent. Associated changes regarding the breast are absent, but in case of malignant you might see some breast changes like nipple retraction or skin thickening or obliteration of retromammary space are all present in case of malignancy. Right? You understand? Now we will discuss something very important. Now this is important for NEET PG as well as Inicet. BIRADS. What is BIRADS? Breast imaging, reporting and data assessment. Breast imaging, reporting and data assessment. Okay, that is the meaning of BIRADS. Now this BIRADS is given for each breast. Now let us discuss some of the various categories of BIRADS and their discussion. Okay, just 1 minute. I'll come in 1 minute. Okay, so back to the class. So we will discuss some of the categories of BIRADS and what they actually mean. So there are actually something like 6 categories in BIRADS, right? You take it like 0, 1, 2, 3, 4, 5 and 6. So there are 6 categories regarding BIRADS. For example, if the person belongs to category 0, this is the category. This is the category 0, category 1, category 2, like that you have up to category 6, right? If the person belongs to category 0, what does that mean? That means either it should be a case of incomplete assessment or it needs other assessment that should be done. Some assessments should be done extra. So the risk of malignancy cannot be determined. Right. Now if it is BIRADS score 1, what does that mean? If the patient has a BIRADS score of 1, that means he is negative for breast cancer, as well as he should undergo annual mammography. That means he should undergo mammography investigation every year. So that is recommended, and the risk of malignancy is 0. If it is BIRADS 2, what does that mean? That means there is a chance of a benign condition that is present in the patient, as well as annual mammography is recommended in this patient also, and the risk of malignancy is 0%. If the patient has BIRADS 3 score, it is probably benign. It is probably benign. Remember, It may probably be a benign condition as well. There should be a short-term follow-up. Remember here, the short-term follow-up should be done to the patient. Short-term follow-up is recommended, and the chance of risk of malignancy is more than 0 to 2%. More than 0 to 2%. Okay, sorry, it's not more than, it's 0 to 2%. Sorry, it's not more than, it is 0 to 2%. So what if it is in case of Birard score? If the patient got a score of 4 regarding Birad's, then you should be suspicious of some sort of maybe malignancy changes in the patient, and biopsy is recommended. And this 4 is further divided into another 3 categories. This 4 score, these patients can be divided into another 3 categories, that is 4A, 4B, 4C. 4A means low suspicion, 4B is moderate suspicious, and 4C is highly suspicious of malignancy. So check in which category the patient is coming regarding these conditions. Now what is the risk regarding all these 3? For example, if you only got information, just you only wrote like the patient belongs to Birad's 4, if it is like only that state, then obviously you can go with the whether the patient belongs to 4A or 4B or 4C category. If the patient belongs to 4A, the risk of malignancy is more than 2 to 10%. Whereas if it is 4B, the risk of malignancy is more than 10 to 50%. More than 10 to 50%. And the risk of malignancy in 4C is more than 50 to 90%. The risk of malignancy. So 4C score of Birad's in any patient is a high risk for malignancy. Now what happens if the patient get a Birard score of 5? It is highly suggestive of malignancy, and intervention is also recommended. Intervention is also recommended, and the risk of malignancy is more than 95%. What happens if the patients get a score of Birard 6? Then obviously it defines that biopsy has proven malignancy. Biopsy has proven malignancy, and there is no need to tell about any risk, because he has been proved that he has a breast cancer. Okay, I mean she has been proved that she has a breast cancer. Okay, happy everyone? Shall we discuss some joke here? I think it's better to have 1 minute rest, or we'll just go on. I just want to discuss some jokes, but I think we are running out of time, so we should go on with the class like that. Yes or no? Yes. So mostly I am expecting a question from the Birards in the Inicet, as well as I am expecting an image regarding the mammography in the Inicet. That's for sure. Either of the topic is sure that you will get in the Inicet this time. That is my 100% guarantee. So just get ready to face the Birard score in a clinical point of view. Don't expect in a direct question. It will be a clinical point of view. Something like, so a 48-year-old female who came with the symptoms of so and so. After a couple of days, the doctor came with a Birard score of 4B. So what is your next suggestion to the patient? What is your next suggestion? Obviously 4B means she has a chance for malignancy that is more than 10 to 50%. So what you will tell? Then you can say like, I am suspecting some sort of malignancy, so better we will confirm it with the help of biopsy. Okay. Okay. So like that you will get so many clinical things, so many clinical aspects, integrated questions. So we'll get into the next thing. So with that we finish the Birard score. I'll give you some tips, some important information regarding this. So what are the common margin patterns, right? For the breast cancer has some margins, no? So what are some common margins that you look in the breast malignancy? Some of the common margins are stellate type of margin, spiculate type of margin, or sometimes comet tail type of margin. So what is this margin, guys? Margin is nothing but, see, for example, this is a breast, there is a nipple, this is a breast, so here it is a breast malignancy tissue, here is the cancerous tissue. Now these are the margins, right? I will draw with green. So these are the margins, right? For example, it can be like a spiculous, or sometimes it can be like a comet tail, like this the tumor can be, or like this the malignancy can be. So that margins, so those margins are here, they can be defined in some types, stellate, speculate and comet tail margins. Now one thing I just want to tell here, that is for breast it is Birard's. Now if there is anything for thyroid, of course there is something that is Tirard's. And if there is anything for prostate, yes, that is Tirard's. Now Tirard's or the thyroid malignancy of Tirard's score is done with the help of sonography, whereas Birard's is done with the help of mammography. And Pirard's or the prostate malignancy is done with the help of MRI. Remember these things, okay? Don't forget. Okay, remember these three facts. Now let's discuss what is the MRI used in breast cancer. It is actually the investigation of choice for breast cancer who are in high risk females. Now what is meant by high risk female? Can anyone tell what is meant by high risk female? Female who is having positive family history, and female who is having BRCA, breast cancer gene mutation. Okay. Now MRI is also an investigation of choice for implant related complications. For example, you have a implant related infection that has occurred in the breast due to a silicone implant. Now you want to define what is the actual condition, then you can go for MRI, right? Now MRI is also investigation of choice to differentiate between a scar and a benign lesion. Investigation of choice to differentiate between a scar and a benign lesion, that is MRI. And it is also an investigation of choice for implant related. Why? Because most of the females, they fantasize like, I should have big breast, I should attract all the males should stare at my breast, they should become mad about my breast. So most of the females think like that. So what they do is they go for implants. And some of the females, why they think like that I don't know, but they feel like, if I don't have big breasts, my husband will not like me, my husband will not have desire on me. See, that is fake. See, men have interest on breasts, but that doesn't mean that men will die for breasts. No, men will have only interest on breasts. No. Of course, men may stare at the breast at the first time, but that doesn't mean that they will bring to a conclusion just by seeing the breasts only. If that is the scenario, then only porn stars will get marriage. No normal women get married, right? So don't think like just because some of the girls have little breasts doesn't mean that boys will not have interest on them. No, see, it's all a different scenario. Sexual attraction is different from something which is spiritual attraction or which is feeling oriented attraction. Obviously at most it comes to sex only, but that doesn't mean boys will have interest only on big books, right? Books means, I think you understand what is meant by book. Okay, so don't think like that. But okay, leave all aside. But why some of the girls, they think like keeping some implants so that their breasts look like engorged, attractive. So if that implants go in the reverse direction, and if that implant causes some unnecessary side effects, ultimately the investigation of choice that you should write on the prescription is MRI. Remember, okay? Now if someone asks you, sir, what is the investigation of choice to differentiate the reoccurrence from scar? Someone asks you, sir, what is the investigation of choice to differentiate the reoccurrence from a scar? Then that will be PET, positron emission tomography. Okay. Now we will discuss something about PET scan. First we will discuss about PET, then we will discuss about ultrasound. It is actually the investigation of choice for the diagnosis of distant metastasis. Distant metastasis. It is the investigation of choice. And the PET is also investigation of choice to differentiate reoccurrence from scarring or scarring fibrosis or necrosis, right? Now if you come to ultrasound, it is the first investigation done in young females whose age is less than 35 years if they come with a complaint of any lump in their breasts. The first investigation is ultrasonography. Now why you should do ultrasonography? Why not you can go for mammography? Anyone? Why ultrasonography is the first investigation that is preferred rather than mammography in females or women whose age is less than 35 years? That means they are young females. Less than 35 means they are young females. Why? Because young females have dense breasts. Have you ever seen a young female breast? I'm not asking like that, but young females' breasts are dense breasts. They have dense breasts as well as they have more of a glandular tissue. So these two features make the breasts of young female inappropriate, or they can't be visualized perfectly in a mammography. So they can be visualized only in a ultrasonography. So ultrasonography is the first investigation that should be done in younger females. Younger females means less than 35 years. All of the doctors, please remember, in the question, please read the age of the women carefully. If it is a younger female that is less than 35 years of age, came with a complaint of lump, the first investigation is ultrasonography. But if it's an older female, more than 35 years of age, came with a complaint of lump, go for mammography. Why mammography in older female? Why mammography in older female? Because older females have lot of fat that replaces glandular and dense tissues in their breast. Fat replaces dense and glandular tissue. So in older females, their breasts have lots amount of fat. So that's why mammography should be done in them as the first investigation. Now coming to the next one, that is bone scan. See, I am not lagging, right? Please, it is concept, so I should tell like this only. So it is the first investigation of choice to diagnose any bony metastasis. Now what is the isotope that is used? That is samarium 153. That is the isotope that is used for painful bony metastasis. The samarium 153 is used for painful bony metastasis. Now let's end up this all investigation information. Now let's come to TNM staging of breast cancer. So you have 4 conditions regarding this TNM staging. One is PTNM, 2 is PTNM, 3 is RTNM, and 4th is MTNM. What is CTNM? CTNM for clinical TNM staging, and PTNM regarding the pathological features, RTNM for recurrent tumors, and MTNM for multiple primary tumors. Okay, now let's get into the TNM classification. Yeah, sorry, I forgot one more thing, that is YTNM. So there is also one more thing, that is YTNM. This staging is done when the patient has received something called a neoadjuvant chemotherapy. Okay, neoadjuvant chemotherapy. Neoadjuvant chemotherapy means before chemotherapy. Neoadjuvant means before chemotherapy. Okay, so this staging, YTNM staging, is done when a patient, if she receive neoadjuvant chemotherapy. Okay, now let's come to the TNM staging according to AJCC, American Journal of Cancer Classification, Cancer Committee. Okay, so TNM staging of breast cancer we will just do now. So if the size of tumor is up to 2 centimeters, it will be T1. If it is more than 2 to 5 centimeters, it is T2. If it is more than 5 centimeters, it is T3. If the size of tumor is more than 5 centimeters, it is T3. Now if the tumor or the condition extended to chest wall, then that is taken as T4A. Now with the spread to chest wall, as well as which involves the skin changes are also observed, then it is T4. Now remember one thing, I want to tell one thing. All the changes should be confined to the same breast only. Don't think like one breast has a tumor, another breast has skin changes. No, that can't be taken like that. All the changes should be confined to the one breast only. Now what are those? For example, we'll go on with, it should have ulceration, then it should have edema including POD orange, or it would have satellite nodules in the same breast only. Okay, in the same breast, then it is categorized under T4B staging, right? Now what is T4C? It is T4B plus A. T4B plus T4A means all the features that are present in T4A and B combined together give the staging of T4C. Now what is T4D? Yes, there is one more stage, that is T4D. That means there is inflammation. there is inflammation, that is inflammatory breast cancer. Now we already discussed inflammatory breast cancer is the most malignant type with worst prognosis. Which is the least malignant type with good prognosis? Tubular carcinoma. Now remember one thing, we discussed about T4 now. So T4 actually doesn't involve some of the following structures, that is dermis alone. It doesn't involve dermis alone. Next, it doesn't involve pectoralis major or minor. Remember this. And one more thing is, it doesn't involve nipple retraction or deviation. This is also important. Okay. I will just tell you one simple information. A patient is having something like a 2 centimeter tumor on their left breast, and the pectoralis muscle is also involved. I will write here, a patient is having 2 centimeters tumor on left breast and pectoralis major is also involved. Now here the staging is T1. Why? Because we already discussed what is that. Pectoralis major or minor is not a part of chest wall. Remember this, very important. Now also the pectoralis major and minor involvement, they do not affect the stage. Remember, the pectoralis major or minor involvement, they do not affect the stage of the breast cancer. And what are the structures that are included in the chest wall? What are the structures that are included in the chest wall? That is ribs, intercostal muscles, then another one is serratus anterior. Nerve to serratus anterior, if injured, leads to what? Or nerve to serratus anterior, also called long thoracic nerve or also called nerve of Dell. If this one injured, what does it cause? It causes something called ringing scapula. This image is a potential MCQ for NEET PG. Just read like this, doctors. Integrate. Okay. Now, coming to the lymph node staging. I think we will stop here, or we shall move on with your wish. Now, coming to the lymph node staging, we will stop here or we will move on. Just we will finish off, right? So, for example, if the metastasis is towards the ipsilateral lymph nodes, if it is towards the ipsilateral lymph nodes, that is ipsilateral lymph node level 1 and 2, that should be mobile, then it is N1. Now, for example, N2A is almost similar to N1, but only it has some slight changes, right? It is the metastasis to the ipsilateral axillary lymph nodes, that is level 1 and level 2, and it should be fixed or matted. Then that can be defined as staging N2A, that is taken as N2A stage. Now N2B is a clinically apparent internal mammary nodes. If there is presence of clinically apparent internal mammary nodes, okay, that is N2B. Now some of the doctors may get a question like, what is meant by clinically apparent internal mammary nodes? Means something which can be detected on clinical examination. These mammary nodes can be detected on clinical examination and they are grossly visible pathologically. They should be grossly visible pathologically, and they can be detected on the radiological examination, but except one thing, that is lymphoscintigraphy. Okay, they can be detected on radiological examination except lymphoscintigraphy. Okay, now that is N2B. Now coming to N3A, if the metastasis is to ipsilateral infraclavicular lymph nodes, that is N3A, taken as N3A. Now if the metastasis is to ipsilateral axillary plus internal mammary lymph nodes, then that is N3B. Now if the metastasis is to ipsilateral supraclavicular lymph nodes, then that is taken as N3C, that is supraclavicular lymph nodes. Now if there is no metastasis, if there is no distant metastasis, then it is taken as M0. If there is a distant metastasis, then it is taken as M1. Okay. Yes. Now we will discuss something about the staging. Staging is important, guys. Now if for example the tumor staging is T1, then obviously it is stage, while right here stage 1. If the tumor staging is T0 to 1 as well as the nodal metastasis is N1, that means it is stage 2, right? Now if the tumor metastasis is stage 2 as well as the nodal metastasis N1, or if the tumor metastasis is stage 3, then the staging will be stage 2B. If the tumor metastasis is 0 to 2 and the nodal metastasis is 2 or N2, then it is stage 3A. If the tumor metastasis is T4 and the nodal metastasis is 0 to 2, then it is 3B. If the tumor metastasis is any of the stage, the tumor metastasis stage is any of the stage with nodal metastasis N3, then it will be taken as 3C. If the tumor metastasis, any of the tumor staging, nodal metastasis, any of the staging, and if there is presence of distant metastasis, then it will be taken as stage. Guys, this staging is very important for Inicet. I am dropping a big star mark. Drawing once again. This will be a potential MCQ. So that's why I will draw this many stars. Please read this. Don't waste it. Okay. Now I will tell you one statement finally. The management of breast cancer, completely depends on this staging only. This staging right now which I have spoken, on this staging only it depends. Now some of the doctors are asking what this one, what are you asking? Which one? T01, T0 to 2, this one, how you will do? See, T0 to 1 means T0N1 or T1N1. So either of it can be considered as stage 2A. That is the meaning of it. For example, here it is T0 to 2 and N2. That means it is T0N2 or T1N2 or T2N2. So any of that may be considered as 3A stage. Any of that may be considered as 3A stage. So like that you understand. Okay. So I will tell you one more thing. For example, if the patient have, let us think like 2 lumps in the same breast. Now the staging is done on what basis? Either it's the big lump or the small lump. The staging is done on the basis of the size of bigger lump. Remember. Now, for example, if the women have lump in each of her breast, that is one lump in right side and another lump in left side of left breast, that is one lump in each of the breast. If the patient has a lump in each breast, then how the staging will be done? In that case, for example, these are the breasts of a woman. For example, this is the right breast, this is the left breast. She has a lump in right breast, she has a lump in left breast. Now, how will the staging be calculated? The staging will be done to both the breasts separately. The staging should be done to both breasts for both lumps. Okay, they should be staged separately. The staging should be done separately. Now, for example, if there is a contralateral lymph node involvement, for example, she has a lump on the right side, and her contralateral left side lymph node involvement is there. Contralateral left side lymph node involvement is there. Now, what does it suggest? It simply suggests she has metastasis. She has undergone for a mets. Coming to the final part of breast cancer, that is management. For example, if it is a early invasive breast cancer, Now, the stages involved are stage 1, stage 2A and stage 2B. In all these patients having early invasive breast cancer, we as clinicians, we opt for which procedure? Breast conservation surgery. Unless or until if there is any sort of contraindication, we simply go for breast cancer surgery. But whenever the breast cancer surgery is performed, right? Whenever the breast cancer surgery is performed, always do axillary lymph node sampling, which is also known as sentinel node lymph node biopsy. Is also performed. Now, in order to prevent the recurrence with surgery, we also do what is that? Radiotherapy. We also do radiotherapy in post-operative period. Right? Now, simply if you want to keep it in a short form, what is the management? You will just keep it in one line, that is breast cancer surgery plus sentinel lymph node biopsy plus radiotherapy. This is the management for all these stages: stage 1, stage 2A, stage 3B, early invasive breast cancer. Now, for example, in case if there is any contraindication, right? In case of any contraindication regarding the breast conservation surgery, what you will do? You simply opt for simple mastectomy. Simple, go for mastectomy, which is also known as total mastectomy. Now, if chemotherapy is given before surgery, what is its called? Previously we discussed. If chemo given before surgery, then it's called neoadjuvant chemotherapy. And if it is given after surgery, then what it is called? It is called adjuvant chemotherapy. Right or wrong? Now, what are the indications of adjuvant chemotherapy? Means, what are the indications for giving chemo after surgery? It is simply early invasive breast cancer. As simple as like that. Okay. Satisfied? Everyone satisfied? Okay. Now if you ask me, sir, what is meant by early invasive breast cancer and what are some of the indications that you can give for adjuvant chemotherapy? Size of the tumor, if it is greater than 1 centimeter, if it is equal to or greater than 1 centimeter. If the lymph node, sentinel lymph node came with a positive report, and if the size of the lymph node is greater than 0.5 centimeters, but the lymph node, if it came as negative with adverse prognostic factors, like see what is meant by adverse prognostic factors regarding lymph node means high histological grade, lymphovascular invasion, hormone receptor. If there is hormone receptor negative, see hormone receptor negative means it is bad prognosis. Hormone receptor positive means it is good. Hormone receptor negative means it is bad prognosis. Next, HER2 neo should be positive. HER2 neo should be positive. So if any of this, you go for neoadjuvant chemotherapy. Go for adjuvant chemotherapy. So not neo. You go for adjuvant chemotherapy. That is chemotherapy after surgery. Now we will discuss something about LABC. LABC, that is locally advanced breast cancer. Now this includes stage 3A, 3B and 3C. 3A, 3B, 3C. Now here before surgery chemo is given, that is neoadjuvant chemotherapy is done before surgery. Why? In order to down the malignancy stage. So we will give neoadjuvant chemotherapy. Now after downstaging the malignancy, we do something called MRM, modified radical mastectomy, right? Now post surgery, after surgery, what you will do? After surgery, we will go for radiotherapy to prevent the recurrence. So what is the management of LABC? Neoadjuvant chemo plus surgery, that is MRM, modified radical mastectomy plus radiotherapy. Okay. So neoadjuvant, see this chemo, actually I should write completely, wait, I will write it down. Neoadjuvant chemotherapy plus modified radical mastectomy plus radiotherapy. That is the treatment for LABC, locally advanced breast cancer. Now for example, if we come to metastatic breast cancer, that is which stage? That is stage 4. Very dangerous stage. It's metastatic breast cancer. So in this, actually we follow two principles. First one is to prolong the survival time of the patient, and simultaneously you should also improve the quality of life of the patient. These two things should be done. Now what you will do? First one is you will use chemotherapy in order to prolong the survival, but obviously chemotherapy also has its side effects. So the status of the patient should be assessed in order to decide whether you should go for hormone therapy or you should go for chemotherapy. This is decided by analyzing the status of the patient, health status of the patient, right? Now generally in this condition, hormone therapy is preferred over chemotherapy. Hormone therapy is preferred one. Okay. And one more thing is, hormone therapy has lesser side effects, so it is preferred, but still hormone therapy has its own indications. Don't go blindly for hormone therapy, it has its own indications, right? Now what are the indications for hormone therapy and chemo? We will discuss here. What are the indications for hormone therapy and chemo? If there is ER/PR positive, you can go for hormone therapy, but if it is ER/PR negative, go for chemo. If there is asymptomatic visceral mets, then you go for hormone therapy. But if there is pure symptomatic visceral mets, you go for chemotherapy. If there is bony or soft tissue mets, you go for hormone. But if the tumor is hormone refractory, you go for chemo. Now, what are the indications for radiotherapy? What are some of the indications for radiotherapy? That is breast conservation surgery. It is an indication for radiotherapy. And if it is a locally advanced breast carcinoma, it is indication for radiotherapy. Why this radiotherapy is given? To prevent recurrence. Now, if there are more than 4 equal to or more than 4 prominent positive lymph nodes, then you go for radiotherapy. And one more thing is, if the patient has positive margins, then also you should go for radiotherapy. Right? What? 1 minute.